the next bit, the document in practice, is kind of from my own kind of personal experience of being a provider chief nurse, but also kind of now working the last 18 months or so, working within an arm's length body, looking at some of the wider kind of system-based issues. And I think Emma's rightly highlighted a number of challenges, which is whilst we've got a great deal of already existing supportive policy and advice in relation to the challenges associated with workforce, the issues are predominantly around the consistency of its application across the system. And colleagues from CQC have often highlighted that despite this, we still find a number of issues and challenges within provider organisations where existing policy or practice or best evidence is not necessarily implemented in the workforce space. That leads to a number of known risks, as well as also unintended consequences in terms of the risk profile for individual organisations. So this kind of next session is really kind of trying to explore some of those issues and challenges, but looking more broadly at the kind of wider workforce context, but also in terms of what this document does in terms of shape the board's behaviour in relation to understanding risk, in terms of mitigating risk, and also importantly, kind of developing strategies to deliver workforce improvements. But I suppose that the first thing to kind of describe to you is some of the challenges of the framework that we're currently operating in. This is obviously publicly held data. We present this as NHS improvement as part of our quarterly annual update. And this kind of highlights the quantum of the, what I term the quantum of the risk that's held by the system in terms of delivering the kind of portfolio of services that you do day in, day out. The headline from this is obviously always invariably around the number of nursing vacancies that exist across the system. But actually, when we start to look at the global impact of the current vacancy position within the NHS provider, it is a significant position of risk, notably around some of our clinical and professional staff. But as you can quite rightly identify, we have significant numbers of vacancy data held in relation to individual providers in other professional groups around this. So whilst the kind of overt focus of policy and support is around both nursing, AHPs and other professional staff, including medical staff, actually the risk is much broader than that in workforce terms, in terms of the delivery for different parts of the system. Now, the majority of the caveat around this, the majority of this gap is mitigated off against utilisation of temporary staffing solutions. And whilst one arm of our business is supporting the system in terms of reduction of use of agency, trying to migrate to bank and support, we actually can't necessarily stand here and say that actually this is not a challenging position because of the nature and the scale of the vacancies that individual providers are things. And the variation in that is quite significant. So we have some trusts who have 3 or 4% vacancy rates, and we have some trusts up towards 25, 30% vacancy rates. So it is hugely variable, and variable up and down the country in terms of the different sectors and the environment we operate in. So it's kind of important to highlight that in terms of the position that we're in. Now, again, to look at some of the kind of variation in that position, I think it's really kind of important to understand that what we see is both sector-based variation and regional-based variation. I think the general view is that your vacancy rates will be higher the more south you are. But we have some particular challenges in mental health and learning disability organisations, and also some particular challenges in terms of the experiences of colleagues who work in the ambulance sector, which I'll come on to at a moment in terms of exploring what this is. So we know that there is a workforce supply constraint in lots of areas of our professional work that's leading to a number of challenges in relation to the vacancy position. There are certain sectors and there are certain parts of the country where that is amplified and far greater problem than we see elsewhere within the country. That is also things, in terms of the variation, if I look at other workforce data, we actually start to see, again, a quite significant distribution in terms of the risks and other areas. So when we start to look at things like sickness as an example, actually the acute sector has one of the lower sickness records. Now, I get the issue around collecting data, and I know there's an underreporting within medical staff. I completely get that. But so before you go, hang on a sec. I do understand that, but if we were to just look at the kind of data that you present back through into the system, we do see some quite significant variations within the sickness data presented. So we know that we've got a quantum of vacancy issue. We know that we've seen an increase in the kind of vacancy, in relation to the sickness challenges within individual organisations. We also, again, in terms of the kind of sickness data, there is quite a significant variation between sectors, but also importantly, there's quite a significant variation in grade. And actually, I think it's important to understand that some of the strategies around this are so we have often some of the lower vacancy rates within our band 2 to 4 cohort, but yet we have higher sickness rates within those group of staff. We have particular risks and challenges in relation to the sort of band 5-6 cohort across all professional groups, and have slightly lower kind of risk. So in terms of understanding the data, I think it's important to understand what you experience from a frontline perspective is mirrored almost across the kind of national picture. As many of you know, we've launched a lot of work in relation to retention across the system. It is the earliest or the most important intervention that we can apply in the short term whilst other supply routes start to come through. So tackling both sickness absence as well as also tackling retention is one of the kind of levers that we are able to deliver in terms of improvement. And the reasons why are because there's quite significant shifts. If I look at kind of registered nursing as an example, the kind of turnover rate, i.e. those people churning and going, moving around the system, has gone up from about 10% in 2009 to just under kind of 14%. That's tens of thousands more individuals. The variation in turnover is quite significant. It ranges from about 4% right up to 30%. Now, don't get me wrong, not all turnover is bad. We actually should have a kind of sweet spot. There is a lot of regional and sector-based variation in that. But actually, low turnover is as big a problem as is very high turnover. If you imagine working in an organisation, the HR leads within this room will know that if you've got a third of your staff in transition at any one point of time, that is an operational risk to handle in terms of the physical quantum of people that is in the case. But most concerningly is actually the leaver rate. These are people who are leaving, so we've stripped out TUPEs and transfers and reorganisations from this data, but this is the people leaving service. These are people who are leaving the NHS. Yes, of course, they may go off to work in private sector, but importantly, actually, a lot of them don't. And this isn't a retirement bubble, so we've analysed the data. People often say to me it's a retirement bubble. It's not. Actually, the greatest level of turnover and leaver rates that we experience in registered nursing within the NHS at the moment is those that are less than 45 years of age. So when we start to look at some of the issues and challenges around retention, we actually find, again, it's reciprocated a lot across the different parts of the sector. Again, in quantum terms, it's disproportionately exposed to the acute, large acute, but actually more importantly, in quantum terms, mental health and learning disability trusts face a far greater challenge in terms of their turnover and retention of staff compared to any other part of our system. And that's important to understand because actually we've seen quite significant declines in the number of overall staff within those kind of sectors. Right. So, this is maybe slightly naughty of me, but I went away and did a little bit of an audit of board papers looking in and around the safe staffing. So, no names shall be mentioned at all in relation to this, but I took a sector and regional-based approach in terms of identifying a number of organisations. I applied the kind of workforce safeguards approach in terms of things, and I'd like to play it back to you today in terms of what I kind of found in relation to doing a thematic review in relation to the audit process. Right. But before I do that, I kind of want to describe to you what I think good looks like in terms of board governance and oversight in relation to that. I know Lorna is going to come and do some work in a minute in relation to kind of the technical nature and the governance, but this is kind of just my lens. This is my lens as a kind of chief nurse looking at what good looks like. A good trust will look at its workforce in the round and not just specifically looking at one individual professional group. And actually, very, very few organisations look at workforce. They look at nurses, they might look at doctors, they might look at AHPs. They'll often is important to cover all wards and departments. We're very myopic. I came from an acute provider trust point of view. We analyse to the nth degree what goes on in wards, but do we apply the same lens to outpatients? Do we apply the same lens to radiology? Do we apply to the same lens to other types of clinical department? Again, we can sometimes be kind of challenged in terms of the approach we do that. Often missed out in kind of board's oversight in relation to staffing issues are theatres and other types of specialty department. And like I say, completely missed are things like outpatients and radiology. So again, I'll come on to some kind of data in that in a moment. the best way to get across to a board a complex problem, and yes, boards are hugely variable, but I know non-exec directors are often really, really interested in getting into the nitty-gritty, in understanding the data that sits behind this. And some of the best ways of approaching this is absolutely playing back to the board, the actual data themselves, whether that's through kind of a formal board meeting or board seminars, and actually providing an opportunity to be able to get into the different tools that are available, explain them, why they're important, what is the triangulation, because that will enrich and develop the kind of conversations that go on in boards. There has to be a clear link to quality outcomes, the operational and also financial performance achieved on individual wards and department areas. Again, looking at kind of workforce in isolation from other types of business approach are a huge challenge if we don't get them right. That absolutely, I know it's a trite phrase, but there has to be ward to board. There has to be a clear link right down to what goes on and what's understood at board, right down to individual challenges within things. And I'll jump a bullet point and say a rationale and approach. So this is my term. This is not an official LHSI term. This is my term. But, having your list of worry wards, as a chief nurse, I often had a number of wards and departments each and every month that really worried us as an organisation. And that wasn't just about the nurses. It was about the culture. It was about the leadership. It was about the delivery. It was about the performance. Having a rationale to do that, other than a kind of gut feeling and some evidence to support that, I think is really important for a board to understand. In big organisations, there will always be 2 or 3 areas that will kind of give you a sleepless night. And having some objectivity about assessing those parts of the organisation is really, really important, so they don't become surprises at board when Ward X or Department Y fall over. And it is important to make sure that those kind of links lead to action. And those actions for a board are not necessarily about micromanaging individual performances of areas, but understanding risks and the issues and mitigations that might be applied to that. So here's the kind of data. So actually, 84% of trusts in the audit publicly stated that they were completing a twice yearly assessment. 84% of those organisations examined pretty much nursing. None examined medical staff, none examined AHPs. 58% examined midwives, 58% examined paediatric nursing. So when I talk about variation and I talk about workforce, it kind of lends itself to the kind of parallel, which is that at boards, we kind of tend to just focus on the nursing staff and not open up that conversation into a broader workforce picture. As critical are our AHP colleagues and as critical are our medical colleagues for the team to be part of that. The areas of focus, again, 100% examined all of the wards within their organisation. 84% examined emergency departments, but only 33% examined outpatients, theatres and radiology. And again, if you look at the kind of CQC approach in relation to inspection, outpatients, radiology, and these sorts of departments are becoming much more of a focus in relation to the kind of staffing and experiences of delivering that. What tools? Well, only a quarter of trusts use the evidence-based tools that were available to them across all of their areas, whether that's maternity, paediatrics, whether that's in medicine or nursing. Only a quarter of trusts use the evidence-based tools. So again, this is kind of a real challenge for us in terms of doing that. The remainder use some tools, but not all, and never necessarily presented the kind of data of those tools provided. In 3 trusts, there was no evidence of any tools being used whatsoever. And that wasn't just their public board papers. I went through their board minutes, their more notes. I went through everything to ensure that I could kind of get a composite view in relation to do that. All trusts had the data in relation to the fill rate on their wards and also, importantly, CHPPD. Now, this is kind of fascinating. Only 50% of trusts ever set themselves some sort of threshold within their organisation on performance in relation to kind of things like fill rates, as an example. And interestingly, the range was quite significant, between 80 and 95% of fill rates for their clinical staff within those kind of environments. So again, there's quite a lot of variation at all. Good to see 84% of patients link their staffing to their quality matrix, but actually only a quarter of trusts flagged any risks that were linked to their risk register or their BAF. Now, these were organisations that were operating quite significant operational challenges in relation to vacancy positions, etc., but only a quarter linked that to some board-level understanding of the risk they held. Accountability, and the chief nurses in the room will smile at this, but 100% of trust noted that the CNO was the nominated accountable officer in relation to staffing. And it kind of tells us something, doesn't it, in relation to the kind of things that Emma's talked about in relation to where we've got to. But we have to broaden that conversation out, hence why the policy has been designed as it. In 16% of cases, when I looked at the minutes of the meeting, the board paper in relation to staffing was passed without any comment or any action whatsoever. So it was just noted, even though in that report was some serious operational and clinical challenges in relation to the portfolio. And 16% of those trusts, there was no minuted action or even any risks identified in relation to managing their workforce portfolio. So I think when Emma does start to talk about some of the variation we have in practice, and we actually look at the adoption of good evidence base that we see already, actually we can notice, even by simply going on and look at what's publicly available, and actually should be quite a transparent conversation with our local communities and providers, we see quite significant variation. And actually, in some cases, it's very difficult without going to see the board themselves. Actually, the question arises is, does the board really truly have a handle on that risk? In some cases, there is some clear evidence that the board hasn't necessarily understood those risks in detail. So in terms of the kind of board, in terms of looking at staffing evidence, it's really important that, the numbers are really important. And I know many of people will say to me, well, it's not also about that, it's about patient experience. Of course, the outcomes are absolutely vital. But there is sufficient statistical and tool-based evidence to support objective assessments in relation to staffing, good or bad. And I kind of preface the fact that I completely understand the operational challenges in working in a context where we've got quite significant challenges in relation to the workforce. But I do disaggregate the really important point. There is one thing operating in a supply-side constraint market where we've got serious challenges in relation to our workforce position. There is a second thing, which is actually being able to articulate what those risks mean for you and your organisation, and importantly, what you're going to do as a response to do that. And we'll come on to other examples about whether or not we close capacity, whether we intervene different mitigations. But actually, my perspective is that actually we need to quantify both what we operate in, but importantly, what that means and translates into operational experience. And the best way, from my experience, to do that is obviously through statistical evidence and the tools that we have available to do that. It is absolutely fundamental that is involved in some level of triangulation. Please absolutely take away, particularly when we look at the NQB document, is the triangulation between the statistical and the evidence-based tools, but professional judgment. Clinicians will tell you when things are challenging, and that's really important to make sure that that's part. And in addition to that is the outcomes that are achieved. And I'll come on to some examples in a moment that maybe might start to get you to start to think about how that triangulation works in a little bit different. Is the acceptance of the evidence, actually, and again, I say this not that it's a kind of easy thing to do at board level, because actually we've got kind of finance challenges, we've got workforce challenges, we've got operational challenges. Trying to have a unitary board discussion about the risks we handle and what to do is really very, very difficult. Accepting the evidence that presents is really hard to do. And it's also important to do that. One of the things that we kind of advocate is absolutely making sure that organisations have really, a decent analytical support. It's really evident when you start to look at this. It's being sometimes done on the hoof. It's sometimes being done without necessarily good support into it. So analytic support is really key. Board preparation is absolutely important to ensure that there's a really broad case discussion in relation to the ability to do that. Again, board seminars, other types of informal environment are really critical to get that right. And importantly, is the kind of important the organisational impact is being able to articulate. One of the key challenges I had as the chief nurse was absolutely making sure whatever analytics and assessment we made at board was meaningful in terms of things. So when we were discussing business cases in relation to investment strategies in wards and departments, actually the team used to come to board to be part of that, to get that kind of clinical view into the kind of board discussion or the chief officer group was kind of critical to do. So engagement within the organisation and understanding the impact around decisions and building a strategy for that is kind of important. And I'll come on to an example of that in a little while. So kind of looking at what looks good is when we kind of describe a kind of ward to board is kind of pigeonholing in three kind of key tranches really. One is kind of the strategic requirements of the organisation, and all of you who kind of work at board or sub-board level will kind of understand that actually there is quite a lot in this space to understand in relation to what workforce means through your board assurance framework, ensuring that you've got the right sufficient numbers to deliver your organisational strategy. You've actually got an agreed model in terms of the care standards and also the resourcing priorities. Now, of course, I appreciate there's 101 assurance mechanisms out there through CQC, NHSI, NHSE, etc. And actually what is important is making sure that those plans fit your approach. And I completely understand some of the difficulties in making sure that there is a complete alignment. Now, sometimes we do see within these kind of presentations and plans is actually there is sometimes a disconnect between what the strategic intent of the organisation is and what the tactical and operational plans feel like when you start to look at the workforce. A good case example is where you see an organisation presenting a reduction in the number of nursing that seems to map or mirror almost identically the balancing item on the finance cost spreadsheet. And that does happen kind of frequently. So it tends to suggest that there is sometimes a disconnect between the kind of intentions of board and also importantly the kind of outcomes that are achieved. The tactical nature is really important because actually that's where a kind of deep engagement can occur with kind of frontline staff and leaders within the organisations, is translating that strategy into different tools in terms of both budget setting, ODP plans, and ensuring that those kind of pathways or service changes are reflected within different models of care. Now, for a lot of people will say, well, actually, we kind of do this. Why are you kind of teaching us to kind of suck eggs? Our experience from kind of the data is these kind of approaches are not often well embedded within organisations. Some do that exceptionally well. Some are very challenged in relation to this. But also important, there is oversight in relation to what you decide in terms of your strategy, the tactical deployment of the resources that you do, and the day-to-day management of how that's delivered. Because the important thing is, for a board, is quantification of risk. And also the rapidity by which the board can get sight of the risks as they evolve. Everybody knows the dynamic nature of workforce and challenges. You know, a ward can go from being well run to being a huge challenge from one shift to the other. The issue for the board is making sure that systems and process highlight that risk early, the mitigations are applied accordingly, and it's not 3, 4, 5 months down the line that one of the worry wards falls over and there's been no board oversight in relation to the risk as that's escalated. So that kind of process is kind of really critical to get right. Now, this is kind of a slightly busy slide, but it kind of trying to represent the two bits for me, which is kind of the techie data on the one side, which is the kind of tools and things that people start to use in relation to determining the staffing types of solutions, versus the kind of operational data and the patient data. And again, sometimes we've seen within organisations that these are often dealt with in isolation. So we see some parts of the business working to one set of principles, whether that's kind of safe staffing, whether that's different tools. On the other hand, they're being held to account in relation to other types of principles, whether that's kind of fill rates or e-rostering problems, or whether that's a financial solution. Bringing that together through a kind of sub-board structure is really kind of important. And one of the keys I put in there, QGC and F&P, people use lots of different names, but we can't disaggregate the quality impact from the financial impact in terms of the sustainability. And my kind of preference is absolutely to ensure organisations are having joint conversations before board, exposing the issues and challenges in both arenas, which is actually, you know, you can deliver a safe, sustainable and quality-based service that doesn't necessarily blow the budgets, but actually it's important there's a clear oversight and understanding between the finance functions, the workforce functions, nursing, medicine and others, and exploring and understanding those issues before they get to board. So taking all of those things in place, the key thing is you collect all of these now. The issue is, how do you bring them together in a conversation, and where do you bring them in a conversation that ensures that those things are able to be discussed and talked about? So what about kind of using the data? This is kind of my real world data. I've kind of used this from my previous organisation where I was kind of chief nurse, in terms of the granular nature of stuff that I was kind of presenting to the board. And actually, these are kind of two graphs that look at kind of, particularly this is looking at an inpatient-based model, looking at some of the variation we had in relation to the kind of acuity modelling that we were doing with different parts of the system. and actually presenting to board some of the significant variations and shifts we'd had within the board profile in terms of the presentation. So again, it's about having conversations, those that are below the line versus those that are above the line. So having the data enables us to have a really gritty conversation about where investment was required, where de-investment was required, and where actually service change and skill mixes were more appropriate to do. So we could build risk-based models to be able to do that. But without having an objective assessment to do that, it's extremely difficult to really articulate to often non-clinicians in board in terms of the scale and the scope of the challenges that different parts of the organisation had. And taking that data, I think, is kind of really important to make sure that, again, all of those things line up to make sure that what is evidence within the operational plan, i.e. what you set out to do as an organisation to deliver your strategic intent of your board, is aligned to the operational requirements to do that. So again, we do see anomalies within the board data where we see a declining number of nurses in an operational plan that says that you will start you'll end the year with probably 2,000 or 3,000 whole-time equivalents less than you started the year, yet your overall demand profile will go up by 2.5, and there's no clear evidence in relation to how that efficiency program will be delivered. So it's not to say that any answer is right or wrong. That entirely may be the case, that a reduction is appropriate. But without the granular detail and understanding and exposing of the risk at board, it's very difficult to see whether those plans come to fruition or not, which is why the business planning process aligned with the tools is really very, very clear to do. And clearly, importantly, to be taken through the board governance process. So by the time it gets to board, you've got a clear idea of where the challenges exist, what the mitigations might look like, and also, importantly, where the risk sits within different parts of the organisation. Now, I can't bring you on to this slide. This is a real-world slide from something I took to my board in terms of exposing the kind of nature and the scope of the problem. So it looks kind of busy. I will kind of explain it, but actually what you have here is a number of inpatient wards. We've put an arbitrary cross point on there, which actually looks at trying to expose a particular issue, which is actually that those wards below the line often have very low, very good outcomes, very, very good outcomes in relation to the delivery of their service. Those that are above the red line on the horizontal axis are those that have got quite significant challenges. And actually, left and right is the kind of acuity data modelling in terms of discussing about how far they are away from their kind of ideal establishment. So the reason for kind of highlighting this is that we actually have some really interesting kind of data in here. If we look at the different quadrants, we've actually got a number of organisations on parts of the organisation on the bottom right-hand side, which absolutely have sufficient numbers of staff based on their modelling and actually delivering outcomes. So it's kind of interesting to look at this group and identify what's going well within that organisation. The bottom left identifies those that actually are delivering quite very good outcomes within the organisation, have something interesting going on in terms of their leadership and organisational model, but actually, according to the data sets, have actually got less than ideal establishments in terms of their organisational model. Above the line is where risk sits. So it's a sliding scale of risk that actually we've got some organisations, parts of the organisation that absolutely are doing have got higher levels of staffing according to their acuity modelling, but actually are delivering worse outcomes than other parts of the system. So again, it's about a conversation where to go. And the top left is where those challenges sit in relation to those parts of the system that have got a serious intractable problem. And we used to use this kind of sentinel graph absolutely as part of a board discussion in a public environment to actually start to think about where the risk sits, where the strategies, what does service change, what does skill mix look like in these environments. And through that was kind of an important part of what we did, linking quality to modelling and the data. There's loads of kind of benchmarking capabilities available. In the old days, and I'm kind of looking at director of nursing colleagues in the room, we used to ring each other up and we'd say, can you send me all of your kind of establishment data so we can measure one part of our organisation to another? And they used to be like secret clubs in different parts of the region where people used to share their data under cloak and dagger methods. And actually, to be fair, you don't need to do that now because actually model hospital. So hands up if you've gone to model hospital. Fantastic. How many of you kind of use it as a kind of operational tool, go in there, look at it fairly frequently? Yeah. There's a huge amount of plug and play capability within the data sets within Model Hospital that enable you to go and look at yourself and many other parts of the organisation. It is just somewhere to go to do that piece of work. I am not expecting people to go, oh, well, I should be at 7.5 on an aggregated CHPPD because that doesn't work. My organisation needs to be at 6.5. It should be part of the conversation. Board members should be able to access this, to be able to start to identify conversations about why we've got some variations in practice. Why are we delivering good outcomes when actually our input model is slightly different to other parts of the system? It's not a right or wrong answer, but it actually provides you with the ability to benchmark in relation to a number of areas. So this is kind of sickness absence, which is again a real world example from an organisation. We can look at that national distribution. You can see where you look in terms of your distribution. Now, people often say to me, well, the whole point of this model is to try and get people down to an aggregated mean. And if everybody was at the average, we'd all be fine and dandy. No, that's wrong. The reason for this is to look for two things. One is unwarranted variation, things that don't make sense. But importantly, it's just as important to find warranted variation. And the practical example I use is gynecology. Gynecology across many, many parts of our system in terms of the standard models, in terms of the application of those kind of service models, often have lower CHPPD when we look at them as a cohort compared to our major large teaching cancer centres. So if your CHPPD in gynecology is 8, I'm making this, no, let me get the right number, it's about 12, compared to core district general service models, which are around about 6. That does not mean that everybody on board should take you from 12 down to 6. Because it means that you need to go and look at your system, and you might have warranted variation because your skill mix, your case mix, etc. generate that. So we're looking for warranted and unwarranted variation to identify the different models of delivery, not necessarily aggregating to a mean to be able to deliver that. Helpfully, within the model hospital, it does enable you to look at some level of cost base and kind of support model. So, you know, they actually look at the weighted units to look at the kind of cost comparison. It absolutely is important to look at this, but again, it looks at a kind of conversation within the board to look at the different types of model, because you know it's not perfect, but it does give you the ability to start comparing different models and different approaches when they're seen in a triangulation in relation to all of the other benchmarking data. So rather than ringing around, every single provider organisation is on Model Hospital. The new better data means that you can now drill down to individual ward level. And please, I'd like to put a massive thank you on the table for the Model Hospital team. So how many wards have we got in the NHS, do you think? Hospital wards and service lines? It's somewhere between about 8 and 10,000, depending on how you name them. Okay, how many names of wards have we got for those 7? Yeah, well, it was 54,000, right? And the reason is because we have multiple different systems in your organisation. So even in your own hospital, you'll have Bluebell Ward, and you'll have BL1 in one system, you'll have BL7, and it will still be called Marjorie Ward in some other system in the things, or it will be called B7 West. So trying to kind of merge those is quite difficult. So again, colleagues have fed back to me that sometimes the specialty mix doesn't work on Model Hospital. Actually, if you do find those anomalies, please do tell us. We have engaged with your information analysts to try and do that as best we can. If there are some anomalies, please let us know. We can kind of annihilate them. We do know that wards move around. We've had one big teaching trust who's contacted us, is doing a complete configuration of their wards, and we've gone into their organisation to understand that their specialty data lines up with the benchmark data on the national picture. So if you find anything like that, then please do let us know. So what kind of difference does it make by kind of exposing some of those kind of challenges on the wards? Well, actually, this is kind of, again, another real-world example from my experience. You know, we wanted to develop a different model of care. We'd identified through benchmarking that there was a need for a kind of investment strategy in there. And actually, when we started to look at the risk profile, it was very evident that actually those kind of investment models needed to be done. Acuity was very low, non-sensitive indicators, but actually they were venting pressure in terms of the use of enhanced care within those kind of environments. There was an obvious economic as well as also clinical decision in relation to an investment strategy within the organisation. Actually, in another environment where we had a very similar pattern, actually we started to look at the skill mix and also, importantly, the clinical pathway. So when we started to look at the different changes of our admission profile, the demographic issues and the dependency shifting, because we had a very similar pattern in the data, it wasn't necessarily an investment strategy. We actually looked at redistributing some of the resources from elsewhere in the system including roughly a 60k investment within from another part of the organisation to be done that. Remodelled the skill mix in relation to both the shift patterns, again by engaging with the frontline leaders. So what was presented as two clinical environments that had identical data pictures, the risk profile, the approaches in relation to kind of the improvement strategy within those places was very, very different based upon a granular understanding in relation to the clinical teams that we were working with. The kind of final section I want to focus on, which kind of comes out within the kind of report, is around kind of new role support. Now, I kind of don't make an apology for this kind of slide being kind of a little bit busy, but when I kind of trained as a nurse many, many years ago, it's kind of fairly evident that what a doctor nurse did and what a nurse did and a therapist did and kind of what people did in the system, the clinical model has changed quite enormously in terms of what that actually means on the practical day-to-day. Some of that has been driven by new roles into the system. Some of that has been organisational change, and also those organisations taking different approaches to workforce within their system. What we kind of have over here on the left-hand side is that actually when we look at kind of the band 2 to 4 workforce support space, we've actually seen quite a lot of innovation in this. We've got the use of therapy assistants, we've got multi-mode practitioners that are a bit nurse, bit therapist, bit IAPT in some cases in mental health trusts. And importantly, in and around the kind of registered space, again, we've got lots of kind of transition around different approaches that organisations are taking in relation to kind of skill mix, as an example. So we've got AHPs now leading clinical teams, rather than necessarily just other AHPs. We've got in rehab settings, we've got AHPs leading wards of nurses. And also we've got the boundary space between the kind of nursing assistant type roles and the assistant practitioner roles, and now when they qualify, the nursing associate. So organisations are taking a pragmatic approach in relation to the global workforce challenges they've got, trying to articulate them into kind of approaches to delivering kind of skill mix change. And we see equally at the same other end of the spectrum. So when we start to look at kind of often around the kind of medical workforce space, we've had a long history of specialist nursing and advanced practitioners. We've got physicians associates starting. We're starting to see the clinical team evolve and model really quite significantly. And if I kind of these are kind of case examples. When you get the slides, it's kind of a lot of detail in there, but they give some really good examples where lots of organisations are actually changing their approach to skill mix design by utilising these roles effectively. Importantly, they're doing so and actually doing it in a really kind of systematic and approach and meaningful way. What is kind of interesting is actually we do this wholesale clinical change, but invariably we very rarely understand the risk and the mitigations that need to go into doing it. So one of the recommendations within the Workforce Safeguards report is where you have a significant and material change in skill mix, actually the organisation should be applying the fairly standard quality impact assessment approach in terms of understanding what that means, the impact for staff, for patients, for outcomes, finances. So the organisation is clearly understanding before it goes into these skill mix changes whether it's the right thing to do, what to monitor, and if it's not going well, what things. Invariably within the NHS, we're pretty quick to go for a workforce solution and change something without necessarily really starting to really articulate and understand what the risk to do. Again, particularly around the kind of the higher clinical decision-making space, we're seeing lots of transition into different kind of skill mix models in different parts of the system, the use of physicians associates, and also advanced clinical care practitioners. It's really important that organisations, before making these changes, are fully articulating and understanding the risks that might things. And in most cases, they are often minimised, they're often very low. But actually, it's important to have a conversation that actually, if we are going to change our neonatal unit from tier 1, from being a relatively fragile junior doctor rota to advanced neonatal practitioners, that the organisation understands what those transition arrangements and risks might look like. Has anybody done a skill mix redesign and done a QIA? Can you put your hands up? Yeah, a few. So when we kind of went around the country, we found some really good case examples where trusts were being very, very upfront and proactive in relation to understanding those risks and putting in good, strong, evidence-based decision and support tools for boards to understand what that might mean like. And it does kind of lead us to a conversation, which is, again, within the document, is trying to give some case examples, but also a kind of framework in which people to do different things. Now, one of the key challenges I always faced as a chief nurse was that some or all parts of the system were under different pressures at times. And often when we spoke to the frontline clinical staff, the pressures of demands of different flows required pressures with challenges. So because of the nature of the way my wards were structured, it was relatively easy to close all or parts of wards at different points in the year. Now, that is an extremely difficult decision to make within an organisation, because you've got ops colleagues saying, please do not shut any capacity whatsoever. Even 10 beds gets us through the night, and I had 1,400. Where there's finance colleagues saying, yes, no, don't stop at 12, close 24, because, you know, we'll save all of that kind of money on it. So I understand some of those dynamics, but actually what's important is having a methodology within the organisation that allows that cross part of organisation discussion about what's the merits and risks of doing that and building a plan. So one of the key things I always found a massive challenge was when to open capacity. Ops colleagues would like it timed, particularly near to winter. Sometimes it was actually about when things were going to be closed. And again, there's some good examples within the document, and again, we'll talk about some of them a little bit later on in relation to different approaches in relation to when to open capacity, what kind of measures should be put into place to do that. Again, when I was chief nurse, I remember opening a ward. We had a long debate about what was a sufficient level of temporary staff versus permanent staff to work on an environment. And we had a professional debate about it and said that it should be around about 60% permanent staff versus 40% temporary staff. Now, those sorts of conversations go up and down the country all the time, and I've seen some which are 100% temporary staffing when opening additional capacity. But our risk appetite was much lower, and we went through a risk assessment process to determine what that was. So there's different places to do that. There's also the challenges around closing it. And I know a couple of examples where colleagues have had to take the very, very difficult decision to close parts of organisations, parts of services, or even stop entirely service models. And again, the document's helpful in terms of describing some approaches in terms of the objective nature of those kind of assessments and the data that does. But it's really important to understand that it's not necessarily the decision that's you shouldn't do, because you should. It's the framework. I remember being interviewed by the CQC. I'd closed a ward or part of a ward, about 12 beds, for operational and staffing reasons, and a good hour of my interview with the CQC was how had I come to that decision? What documents did I have? How much was board cited on it? This was just closing 12 beds out of 1,400. But it was really evident they wanted to look at process. They wanted to look at how it had been signed off, what engagement had taken place, how it understood that. Did the frontline understand the decisions? What were our criteria for reopening? What was our criteria for keeping closed? And what was our criteria for closing even more? So it wasn't about the decision. It was the process and the governance that kind of fitted in around that was really, really kind of evident. So I've only got kind of a minute left before I hand over to my colleague Miles from Maidstone and Tunbridge Wells. But I hope this kind of session has really kind of brought out some of the issues and challenges and why the policy was devolved and developed in the first place, in terms of really trying to get aligned and alongside some of the really important challenges that we have within our providers, recognising on one hand the workforce issues that you deal with, but also importantly kind of focusing in on process, the board, and broadening out the responsibility of workforce to the wider board, rather than necessarily it sitting with one or two executive directors that can be in some case a pretty lonely place when you're fighting a number of fires on all sorts of fronts in relation to the workforce challenges within the organisation, kind of building across that concept in relation to the unitary board. So I'd just like to say thank you for the team who've helped me kind of bring some of this together. Obviously, I've kind of hopefully shared with you some of my own kind of personal experiences in trying to work within this kind of space and some of the challenges that I have. And I think I can probably take one or two questions. Tony, am I allowed to do that? Yes, one or two questions before we finish, and I invite my colleague Miles to the stage. No, I got out of that one, didn't I? Excellent. Oh, lady in the middle. Yes.
We quite often do QIA and EIA when we're looking at service transformations in a kind of turnaround context.
Yeah.
So my question, I guess, is are there examples of people who do them really well? Because when when you're doing them, you can quite often just get into a bit of it's part of the project plan and you have to do it. So I'd be kind of almost interested in anyone that can offer support or guidance in doing good quality QIAs and EIAs.
Well, I may be biased, but I have two of the finest people around board governance working in my team, Lorna and Becky, and Lorna is here today to do a session. Lorna, will you cover QIA within your governance discussion?
I think she's just left the room.
Gotcha.
Yeah, I think she is, yes.
But she is going to cover QIA.
Now.
She is now, anyway. But yes, you're right. We often think of quality impact assessment in kind of quite, CIP terms and kind of service change terms. But actually, when I start to look at some of the kind of changes we're making in workforce, whether it's changing of service models, skill mix redesign, investment strategies, very rarely do we see the level of analysis that goes into a QIA for, say, a CIP versus what we do when we're quite materially changing some of the risk profiles that might exist in a ward and a department. So yes, we do have a number of really good case examples, and I think Lorna's going to go and describe actually what that kind of process looked like, what does kind of good look like as well. But if there's a specific support requirement, please come and see me and we can kind of support something like that. Karen.
Hi Mark. I just wanted to ask a question. You mentioned about data analytics are really important, and I absolutely agree with you. But there'll be a number of us in the room that are in organisations where we don't have that level of expertise or maturity in the teams. Are you able to offer us anything or point us in a direction where we can pick up that sort of expertise?
Yes, absolutely. So a lot of you will have information teams within your organisations. A lot of you will have really good analysts, but they'll often be hugely overburdened with requests and things. So we've got a workforce analytics team at NHSI. We've got a team of 4 or 5 people who've got huge experience at provider level and also who can come if you have a specific request to look at your kind of reporting ways, kind of analytics you might want to apply to the problem. We can come to your organisation and support you to do that, or we can do it remotely, and we're also available to offer kind of remote feedback if you want us to look at board reports or governance models. Again, we can do that offline, so that's no problems at all. Great. Right, one more question before, yes. Oh, hello, hi.
From NHS Improvement, hi. I just wondered if you could just say a little bit more about the SOF and how the work that you're describing today links with the SOF, so we can understand what that regulatory framework might look like in association with this element.
Yep. So assuring safe staffing has been bolted into the existing SOF framework in relation to the delivery of the service model. So we haven't revised SOF as a relation to this. We will not be applying a risk-based model to your organisation that will change your SOF. This is the first year of our assurance process in relation to safe staffing. So what we're looking for organisations to do is to provide a comprehensive overview. So in the first year, we're assessing whether or not you've adopted this framework, that the kind of inputs and outputs are described at board level, so are you taking the right type of information? And we will work with you over this next year to enable that to get that right and to sharpen it up so we can get the consistency across the system. Into year 2, what we also are starting to want to explore with trusts is to identify the risks in the system. And this is working with individual trusts and systems to know which organisations are particularly stressed under this kind of framework. So once they've done their assessments, they've identified where their risks are they greater or larger than other parts of the organisation? So we can have a sliding scale of support right through from a kind of soft 1, which is kind of leave you alone, well done, crack on, right down to soft 4, which is where we kind of might need to kind of help and support you in making those decisions. The moment we do that, but we tend to do that through the kind of regional assessment, which is often purely based upon the regional knowledge and local knowledge of that organisation. We want to objectively measure this so we know that the consistency is being applied. So it will be in 2 phases. Year 1, embedding approaches within organisations and ourselves. Year 2, probably moving to a more risk-based approach and identifying those challenges within organisations and work with you to kind of make sure that that's delivered.